In Loma Linda, California, women in their 70s and 80s move through menopause without the suffering that has become normal everywhere else. In the United States broadly, 85% of women report struggling with menopausal symptoms. Only 10.5% receive any treatment or therapy at all. Same species, same biology, same hormonal decline. The only thing separably different is what happens in the years leading up to that transition, and what support exists when it arrives. Dr. Mary Claire Haver, a board-certified OB/GYN with more than 2 million followers, has spent the last decade documenting why the medical system fails menopausal women and what the world's healthiest populations do differently. Her central finding is this: menopause is inevitable, suffering is not. In this video, we're covering 3 things. First, why 85% are suffering without help. Second, what Loma Linda women do that the rest of us don't. And third, the complete toolkit you can start using today. Here is what is actually happening. The medical system is not equipped to handle menopause. It never has been, and most physicians practicing today were never trained to recognize it as anything beyond hot flashes and night sweats. Dr. Haver completed her OB/GYN residency in 2002, one of the last groups of physicians in the United States who received any training in hormone replacement therapy at all. During that training, there was a term used among upper-level residents when a woman in her 40s or 50s came in with multiple complaints: brain fog, sleep disruption, weight gain, joint pain, mood changes. They called her a whiny woman. That was the code. It was never written in charts. It was never taught by faculty. It was handed down as part of the culture of training. What those residents didn't recognize, and what most physicians still don't recognize, is that those women were perimenopausal. They were experiencing the documented multi-organ system effects of declining estrogen and testosterone. The laundry list of symptoms had one root cause. The medical response was dismissal. Then, in 2002, the Women's Health Initiative study was stopped early. A press conference was held at the Watergate Hotel in Washington. Every major news outlet attended. The announcement was that estrogen causes breast cancer. What actually happened in that study was this: women on estrogen plus a synthetic progestin saw their absolute risk of breast cancer increase from 4 out of 1,000 per year to 5 out of 1,000 per year. One additional case per 1,000 women treated. That is a 25% relative risk increase, and that is the statistic that destroyed hormone therapy access for an entire generation of women. The estrogen-only arm of the study, which continued for several more years, showed a 20% reduction in breast cancer risk and a 40% reduction in mortality. That data has been published. It has been peer-reviewed. The original findings have been walked back repeatedly. None of it matters. The damage was done. Today, a woman suffering from menopause is more likely to be prescribed an antidepressant than hormone therapy. She will see 7 or 8 different specialists. She will leave with 9 medications treating 9 separate symptoms when one intervention could have addressed the root cause. That is the system women are walking into right now. Before we can understand what works, we need to understand what menopause actually is and what it does to the body. The distinction matters because most people, including most physicians, still think of menopause as a few uncomfortable symptoms that resolve on their own. That understanding is decades out of date. Here is what is happening at the biological level. Females are born with all the eggs they will ever have. Those eggs develop while the fetus is in the womb at around 5 months of gestation. That is the maximum egg supply. It declines from that point forward. By age 30, a woman is down to about 10% of her original egg supply. By age 40, she is at 3%. When the supply drops low enough, the body can no longer produce the cyclical surges of estrogen and progesterone that defined reproductive years. That is menopause. The average age in the United States and most of Europe is 51. Perimenopause, the phase where symptoms begin, starts 7 to 10 years earlier. That means a 35-year-old woman can begin experiencing perimenopausal symptoms, and most will never connect what is happening to hormones. Estrogen is not just a reproductive hormone. It has receptors in every organ system of the body. It is a powerful anti-inflammatory molecule. When estrogen levels begin to fluctuate and then decline, inflammation increases throughout the body. The effects show up everywhere: brain fog and memory issues are not imagined. They are documented cognitive changes tied directly to estrogen withdrawal. Depression and anxiety either emerge for the first time or worsen dramatically in women who were previously stable. Studies show that women who start hormone therapy in perimenopause have a significantly lower incidence of new-onset depression compared to those who do not. The musculoskeletal system is hit hard. Frozen shoulder, a condition where the joint capsule becomes inflamed and adhesed, is extremely common in menopause. Joint pain, generalized aching, and loss of flexibility happen because estrogen is no longer protecting those tissues from chronic inflammation. Cardiovascular risk increases independent of aging. Menopause is its own risk factor. Insulin resistance spikes. Cholesterol levels change even when diet and exercise remain constant. Diabetes risk goes up. The genitourinary system deteriorates. Vaginal and bladder tissue become thin and lose elasticity. Painful intercourse and recurrent urinary tract infections follow. UTIs are a major cause of death in older women, and vaginal estrogen, which is safe even for women with a history of breast cancer, could prevent the majority of those infections. It is rarely offered. Bone density collapses. In the first 10 years after menopause, women can lose 10% to 15% of their muscle mass. Muscle and bone operate as one system. Low muscle mass accelerates osteoporosis. 50% of women will experience an osteoporotic fracture before they die. Of women who fracture a hip, 30% will die within the first year, even with surgery. 70% will die within that year without it. That year is marked by immobility and severe pain. Most of this is preventable. The body is not failing because of age. It is failing because a protective hormone has been removed, and the medical system is not responding. That is what menopause does when it is left unsupported. Loma Linda, California, is one of 5 blue zones documented globally. Blue zones are regions where people live measurably longer and remain functional later into life than populations elsewhere. Loma Linda has the highest concentration of centenarians in the United States. The women in this population do not suffer through menopause the way women in the rest of the country do. That is not anecdotal. It is observed and documented across decades of public health research. The difference is not genetic. Loma Linda residents are not born with a biological advantage the rest of us lack. The difference is not a supplement or a rare food or a medical intervention that starts at age 50. The difference is a lifestyle architecture built decades before menopause ever arrives. By the time a woman in Loma Linda reaches perimenopause, her body is already metabolically protected in ways that most Western women are not. 4 systems are embedded into daily life long before hormones begin to decline. Whole food plant-based nutrition, consistent strength-building movement, community support structures, and stress reduction practices. These are not things that get added when symptoms appear. They are the baseline. The anti-inflammatory advantage starts with diet. Chronic inflammation is one of the primary drivers of accelerated aging. Menopause dramatically increases chronic inflammation because estrogen, which suppresses inflammation throughout the body, is no longer present. Women in Loma Linda eat diets naturally high in fiber, rich in vegetables, fruits, nuts, seeds, and legumes. That dietary pattern reduces systemic inflammation before the estrogen drop ever happens. When menopause arrives, the body is not starting from a place of existing inflammatory burden. It has a buffer. Muscle mass is preserved through physical work and resistance-based activity maintained across the lifespan. These women do not go to gyms. They do not follow structured workout programs with progressive overload protocols. They move consistently as part of daily life. Gardening, walking, manual labor, tasks that require the body to bear load and resist force. By the time they reach menopause, they have not spent 30 years doing only cardio in an effort to stay thin. They have spent 30 years building and maintaining muscle. That muscle protects them from the rapid sarcopenia and bone density loss that happens in the first decade after menopause elsewhere. The social safety net is structural, not incidental. Shared purpose groups, regular community meals, accountability that does not feel like pressure. Loneliness and social isolation are independent risk factors for early mortality and functional decline. In Loma Linda, those risk factors are systematically reduced through built-in social infrastructure. Women are not managing menopause alone. They are surrounded by others going through the same transition. Sleep is prioritized. Early to bed, early to rise rhythms aligned with natural light cycles. Minimal artificial stimulation at night. Stress is managed through faith practices, meditation, time in nature, and slower-paced living. The critical insight here is this. Loma Linda, women do not manage menopause. They arrive at menopause already protected. The lifestyle that produces longevity in every other area of health is the same lifestyle that makes menopause survivable. You cannot move to Loma Linda, but you can replicate the system. That is what the rest of this video covers. Dr. Haver's first realization came from her own patients. Women in their 40s and 50s were gaining weight despite no changes to diet or exercise. They were still working out. They were eating the same foods. The only variable that had changed was their hormones. The standard medical advice she had been trained to give was work out more, eat less. Calories in, calories out. That framework does not account for what happens metabolically when estrogen and testosterone decline. It treats the body as a static machine when the body is a dynamic endocrine system. Dr. Haver went back to school. She enrolled in the culinary medicine program at Tulane University because she realized there was a piece missing. Medical school had provided almost no education on nutrition. Residency provided even less. She needed to understand what food actually does at the cellular level and how it interacts with the hormonal changes of menopause. What she developed became the Galveston diet. It is built on 3 principles: anti-inflammatory eating, fiber focus, and fuel refocus. The goal is not calorie restriction. The goal is metabolic support during a period when the body's regulatory systems are under stress. Anti-inflammatory nutrition matters because menopause removes estrogen's protective effect against chronic inflammation. Chronic inflammation is low-grade, persistent, under the radar. It drives cardiovascular disease, diabetes, dementia, and accelerated aging. The single biggest dietary contributor to chronic inflammation is added sugar. The target is under 25 grams of added sugar per day. That does not mean zero carbohydrates. It means minimizing processed sugars that spike insulin and drive inflammatory pathways. Foods that reduce inflammation are whole foods. Cruciferous vegetables like broccoli, Brussels sprouts, and cauliflower. Berries, which are high in polyphenols. Nuts and seeds, which provide healthy fats and fiber. Avocados. Leafy greens. These are not exotic. They are available in every supermarket. The common feature is fiber. Fiber is what creates the crunch in vegetables, asparagus, celery, apples. If it is crunchy, it contains fiber. Most women are consuming about 12 grams of fiber per day. The minimum target is 25 grams. Fiber does 3 things. It slows the absorption of glucose into the bloodstream, which keeps insulin levels lower over time. It feeds the gut microbiome. Soluble fiber, the kind that dissolves in water, is the food source for beneficial gut bacteria. Those bacteria produce short-chain fatty acids called butyrates. High levels of butyrate are associated with lower rates of coronary artery disease, dementia, and systemic inflammation. Fiber also pulls water into the gut and moves waste through the digestive system more efficiently. There is no fiber in lean meat. It has to come from plants. Vitamin D deficiency is present in 85% of menopausal women Dr. Haver tests, not low. Deficient. Vitamin D is both a vitamin and a hormone. It has receptors throughout the body, including the brain. Deficiency is linked to hypertension, diabetes, stroke, depression, and poor calcium absorption, which accelerates bone loss. The gut's ability to absorb vitamin D decreases during menopause. Supplementation and regular blood work monitoring are necessary for most women. This is first-line intervention. These are not optional adjustments. They are foundational. Protein intake becomes critical in menopause, and most women are not consuming enough. The loss of estrogen and testosterone tears muscle tissue apart. That is not metaphorical. Those hormones are anabolic. They support muscle protein synthesis. When they decline, the body shifts toward a catabolic state. Muscle breaks down faster than it rebuilds. In the first 10 years after menopause, women can lose 10% to 15% of their muscle mass. That loss is not cosmetic. Muscle mass determines insulin sensitivity. metabolic rate, bone density, and functional mobility. It determines whether you can stand from a chair without using your hands at age 70. It determines whether you recover from a fall or fracture a hip. Doctor. Haver's original dietary framework emphasized healthy fats and moderate protein at around 20%. If she were writing it again today, she would go much higher on protein. The research on protein needs in menopausal and postmenopausal women has advanced significantly. Higher protein intake supports muscle preservation when combined with resistance training. Creatine supplementation, which most women have never considered, shows documented benefits. Studies in adults over 65 demonstrate that creatine combined with resistance training produces greater gains in muscle mass and strength compared to training alone. The dose is typically 3 to 5 grams per day. It is one of the most researched supplements available, and the safety profile is well established. The other nutritional tool that matters is intermittent fasting. This is not a weight loss strategy. The data on fasting for weight loss is inconsistent at best. You can undo any benefit by eating poorly during your eating window. The reason to fast is systemic inflammation reduction and improved insulin sensitivity. The research that supports this comes primarily from Dr. Mark Mattson's work on neuroinflammation and metabolic health. A 16-hour fasting window followed by an 8-hour eating window is the most common protocol. That means finishing dinner by 8 in the evening and not eating again until noon the next day. The adaptation period takes about 6 weeks. The body needs time to adjust to using stored fat for fuel instead of relying on constant glucose intake. Dr. Haver recommends extending the fasting window in 15-minute increments over several weeks, rather than jumping directly to 16 hours. Start at 12 hours, move to 12 hours 15 minutes after a few days. Keep advancing gradually. By week 5 or 6, the body has adapted. Hunger in the morning diminishes. Mental clarity during fasted hours improves. The brain runs efficiently on ketones, which are produced when the body shifts to fat metabolism. Fasting is not appropriate for everyone. It should be avoided by anyone with a history of eating disorders, active diabetes requiring medication, or hypoglycemia. For most women, it is a tool worth experimenting with under the guidance of a healthcare provider. The philosophy shift that matters most is this: strength over skinny. The generation that came through aerobics in the 80s and 90s was taught that small equals healthy. Thinness was the goal. Muscle was never prioritized. That generation is now in menopause and paying the metabolic cost of decades spent focused on the wrong outcome. Resistance training is not optional in menopause. It is the single most important intervention for preserving functional mobility and metabolic health in the decades that follow. The muscle mass you maintain through your 50s, 60s, and 70s determines whether you remain independent or require assistance with basic tasks. It determines your resistance to insulin. It determines whether your bones can withstand impact or fracture under minor stress. The musculoskeletal system operates as one unit. You cannot protect bone density without protecting muscle mass. They are mechanically and metabolically linked. Dr. Haver spent decades doing cardio. She came from the aerobics generation where the goal was to be thin and small. She now has sarcopenia, a clinical diagnosis of low muscle mass. That outcome was not inevitable. It was the result of prioritizing the wrong type of exercise for 30 years. She is now focused entirely on resistance training, weighted vest walks on an incline, lifting, movements that place load on the skeletal system and force muscles to adapt. She uses a body composition scanner in her clinic that measures muscle mass and visceral fat separately from total body weight. The number on the scale is not the relevant data point. What matters is how much of that weight is muscle and how much is fat. One of her patients came in overweight, not sleeping, experiencing brain fog and joint pain. Typical presentation. She started hormone therapy, hired a personal trainer, and committed to resistance training 3 to 4 times per week. Over the course of a year, she lost 60 pounds of body fat and gained 10 pounds of muscle. Her total weight dropped 50 pounds, but the composition shift was far more significant. She feels better than she has in years. Her intimacy with her husband is restored. She is vocal on social media about her results because she cannot believe she suffered as long as she did without seeking help. The thing that makes her angry is not that the process was difficult. It is that no one told her it was possible. Here is the test you can do right now. Stand up from your seat without using your hands. If you needed to push off with one or both hands, your hip flexors, glutes, and core are not coordinating properly. That coordination gap is a functional deficit that worsens over time if it is not addressed. Resistance training directly targets that gap. Within weeks of consistent practice, most people notice measurable improvement in that specific task, not a transformation, a specific observable change that you can track in your own body. The message for women in their 30s is this: build muscle now while it is easier. The muscle you build at 35 is muscle you take into menopause. You are banking it. The alternative is arriving at menopause already sarcopenic and trying to rebuild from a deficit. One pathway is preventable. The other is much harder to reverse. Menopause is inevitable. Suffering is not. The medical system has failed an entire generation of women, but that failure does not mean you are without options. Loma Linda proves that lifestyle architecture built before menopause arrives changes the entire trajectory. Nutrition, resistance training, sleep, stress reduction, and community support are not secondary interventions. They are primary. Hormone therapy is one tool in a larger system. It is safe and effective for most women when started early, but it is not the only answer. The responsibility now falls on you to advocate for yourself. Print research. Find a knowledgeable provider. Track your symptoms. Demand better care. You are not crazy. This is real. 1.2 billion women are navigating this transition right now, and most are doing it without adequate information or support. You do not have to be one of them. If this video helped, subscribe. One Blue Zone practice per video. Systems you can use this week.